so that we could, Dr. Sejal is going to do a series on fetal echo so that she can have a 1 week gap between each talk, so you don't get too much of fetal echo all in a row. So every Tuesday we'll try and do something on fetal echo till we cover it. So we'll get started. This is my quiz for the morning. So you can't see it, Kavita. I've put the quiz. Keep your, for those who it's the first time, just put your answers into the chat box and send it to all so everybody can see it. So what is the diagnosis here, and can you list some causes of this? This is a 4-chamber echo view. Let me put my glasses on, see what you guys say. So anyone? What's the diagnosis? 4-chamber view of the heart. So you can see the black area outside of the heart. The right atrium, right ventricle look a little compressed. So this is a large pericardial effusion. Tamponade is a clinical finding. So here all you can say is that this is a pericardial effusion. Can you give a few causes of pericardial effusion in kids? When you see a large pericardial effusion, what is your differential diagnosis? What should you start looking at, thinking about as a differential diagnosis for pericardial effusion in pediatrics? Anyone? You just put on the chat box here. Everyone needs their coffee? So you put your answers in there so that everyone can see it. So generally when you see a large pericardial effusion, there's a kind of a differential diagnosis. For instance, if it's a female teenager, what would be likely as a diagnosis? You start thinking of lupus, right? Yes. If it's a very toxic patient and you see strands inside the effusion, what do you think of? Then you think of something like a staph endocarditis, a staph pericarditis with pericardial effusion, right? If the patient has creatinine of 4, what do you think of? You think of renal failure with effusions. So if the patient has just had surgery a few weeks ago, then what do you think of? Say it's a post-op ASD closure and they come with this big effusion. What is your diagnosis? Is Dressler syndrome or post-pericardiotomy syndrome? What if the patient has no history of anything? This is an acute history of getting breathless, dyspnea, which gets better when they sit forward, gets worse when they lie down, and it's an acute 2-day history. What do you think of? So 2 days ago he was fine and today he's so sick. So what's your diagnosis? What can give you acute pericardial effusions? So he didn't have it 2 days ago and he has one now. Then you've got to think of viral, right? So as you can see, the differential diagnosis varies based on the presentation. So viral infections like CMV, Coxsackie, echovirus can give you effusions. Autoimmune disorders like lupus and rheumatoid. Then you can have your Dressler syndrome or post-pericardiotomy syndromes, which are typically post-op, can also be post-trauma and in adults post-myocardial infarction. Intrapericardial teratomas. If you have an effusion that keeps recurring, you need to do a CT or an MR and look for an intrapericardial teratoma. And then, of course, uremia and bacterial infections and tuberculosis. So as you can see here, the differential diagnosis will also determine your management, right? Because if it's a viral infection, for instance, maybe you use interferon, depending on the virus. If it's autoimmune, you're going to treat it with steroids. If it's post-pericardiotomy, if it's Dressler's, how will you treat it? What is the treatment for Dressler syndrome? Anyone? Treatment for Dressler's? So, NSAID. So you're going to use ibuprofen or indomethacin, right? Ibuprofen is also fine for Dressler's. If it's an intrapericardial teratoma, you need to remove it. If it's uremia, you need to treat the renal failure. If it's a staph infection, how will you treat it? If it's a staph pericarditis, how do you treat? They tend to be very toxic, very sick, with a lot of strands. This is not a staph. Staph will have a lot of strands inside the effusion, and how do you treat that? So you would give IV antibiotics, right? But if patient's very toxic and it's a large, rapidly increasing pericardial effusion, then you need to also many times go in and drain and clean it out for them to get fully better if they're not responding to IV antibiotics. If it's TB, how do you treat? You're not going to drain it because then you'll have all your tracts, but you're going to give anti-tuberculous therapy. So therefore, it's important when you see an effusion to think of this differential diagnosis and investigate accordingly and treat accordingly. Okay. Next one, these are all spotters. This is an angiogram. Diagnosis, anyone? What is this catheter? And where are they injecting? Oops, I gave you the answer. So this is a Amplatz catheter. They're injecting in the coronary system. And you see these are actually giant coronary aneurysms. What is the definition of a giant aneurysm of the coronary artery? When you say coronary artery aneurysm which is giant, what is that size? Anyone? The size for a coronary artery aneurysm that is giant? Size for giant coronary artery aneurysms. So in Kawasaki disease, as we know, they can present with fever, lymphadenopathy, strawberry tongue, rashes, and typically untreated, all of these things go away. But if you don't give IVIG on time, 50% of them will get coronary aneurysms. If you give IVIG, 2 grams per kilo intravenous immunoglobulin on time, then only 5% will get coronary aneurysms. So giving IVIG on time, and what is on time in Kawasaki? When do you have to give the IVIG? Once you diagnose Kawasaki, you should give IVIG within how many days? In order to prevent, so acute phase means how many days? You'll only diagnose it after 5 days of fever, right? Because till then they'll be ruling out other things. It's only 5 days of unexplained fever. Will you diagnose Kawasaki? So when would you give IVIG? When is it, let us say, when is the outer limit till which you can give? Is it 10 days, 12 days, 15 days, 20 days? 10 days. So within 10 days of the fever is when you have to give the IVIG in order to have the benefit on preventing coronary artery aneurysms. So important to note that with IVIG, 5% chance of coronary aneurysms. Without IVIG given on time, 50% will have coronary aneurysms and high chance of also getting giant aneurysms. And therefore, the importance of early diagnosis and early treatment of Kawasaki. So this is an example of a Kawasaki, post-Kawasaki, now with giant aneurysms. Now, when will you typically see these aneurysms? Let us say today you have 5 days of fever. On 7th day, you've given IVIG. You did an echo on the 6th day. Would you see the giant aneurysms? When do you typically see the giant, any aneurysm? Forget about giant. When do you typically see an aneurysm after Kawasaki? Anyone? Anyone? So say you do a baseline echo, right? Typically when a Kawasaki, a pediatrician suspects Kawasaki, he will send the patient to the cardiologist for an echo. Now that echo is a baseline echo. It's important to remember that that echo may be entirely 100% normal. A normal echo during the fever does not tell you this is not Kawasaki. Kawasaki is a clinical diagnosis. Fever, rash, strawberry tongue, lymph nodes, all other things excluded. Then pediatrician thinks of Kawasaki. So very important as a pediatric cardiologist to then say, this is a normal baseline echo. However, if you're clinically suspecting Kawasaki, please go ahead and give the IVIG and send them back to me for an echo at 6 weeks after the IVIG. So between 4 to 6 weeks after the acute illness is when the aneurysms will manifest themselves. They do not manifest themselves on the first echo. So that is why we say give IVIG within 10 days. Put the child on aspirin because you don't know if he'll develop aneurysms or not. Repeat the echo at 6 weeks. If there are no aneurysms at 6 weeks, stop the aspirin. If there are aneurysms, then you continue the aspirin. Okay, all clear on this? So next one. This is a angiogram. What catheter is this? Are some of you first year fellows? Some are new, a few. I see some new names. So this is a pigtail catheter. What arch? Left arch, right arch? Okay, Ronak. You just joined a month ago then, that means, right? Few months. Yes, so this is a right arch. So let me see if I can annotate here. You see here, one second. So it's going here. It crosses over the right bronchus and comes down. So this is a right arch with a right descent. Now, what else? Read this angiogram. This is a still image pigtail catheter in the ascending aorta, showing you a right arch with right descent. What else are you seeing? Anyone? What else are you seeing? So it's filling the coronary, yes, and filling the right pulmonary artery. So everybody see here, this going out here from the ascending aorta is the right pulmonary artery. So what is that diagnosis when the right pulmonary artery comes out from the aorta? What is that diagnosis? So right pulmonary artery coming out from the aorta. What is the diagnosis? That is a hemi-truncus, or what we call anomalous origin of RPA from aorta. Now, what else do you see in this patient's still image? What are this? What are these all these things in here? What are these things? What is this? These are sternal wires, right? Sternal wires are made of what material? What material are sternal wires made of? Anyone? Stainless steel. So sternal wires. So these are stainless steel sternal wires. But patient has anomalous origin of the right pulmonary artery, right? So your diagnosis, if you were given this to read, would be pigtail catheter in the ascending aorta, demonstrating a right aortic arch with right descent, and anomalous origin of the right pulmonary artery from the ascending aorta, with presence of sternal wires, suggesting that possibly this diagnosis was missed when the patient went for whatever surgery he went for, right? So now read this angiogram. Anyone? What is happening here? So here is an AP view, right? You can see the intervertebral facets aligned. So this is an AP view. Again, you're seeing the sternal wires. You have, maybe it's a Berman catheter in the right ventricle, right? And you're seeing a dilated, you're seeing narrowing in the RVOT and then a dilated MPA. Yes, and you're seeing a left pulmonary artery. So everybody sees that, right? So here, this is your dilated MPA, right? Here's your narrowing, this here. Looks like there's muscle here. You see all this white thing in the RVOT, that's all muscle. And then you're seeing your LPA. Now, where is your RPA? So what is your diagnosis here? If you were just given this angio, your diagnosis is a dilated MPA, which would suggest maybe valvar PS or something, with absent RPA. you should have an RPA coming out here, right? So this would be a case of an absent right pulmonary artery if you were to look at this angiogram. So this patient had an absent RPA with a dilated MPA and LPA. He's actually a post-op case of TET absent valve, but the RPA from aorta was missed. So when they went in, they did the repair, but the RPA, they didn't know it was a hemituncus. So the moral of the story is, even in something that looks like a very normal, TET or a routine what we call diagnosis, it's very important to look always that you see proper confluence and flow from MPA going into RPA and LPA. Many times you'll see both the branches, but you have to document flow going from MPA into RPA and LPA so that you don't miss the RPA or LPA arising from somewhere else and not from the MPA. Okay, all clear? Another spotter for you, anyone? So this is torsades de points. So you can see, let us say this was your baseline. You have wide QRS above the baseline, right? And then you have below, and then it goes above, and then it goes below. So this is torsades de points. What is the treatment for this? Treatment for torsades? So you can give magnesium. You can. What else? Anything else you can do if they have torsades? You will have to also defibrillate them, right, in the acute stage, and then look for long QT and treat accordingly. Okay. Now we'll move on to pregnancy and cardiac lesions. So I want you to name some cardiac lesions which are well tolerated in pregnancy. Some cardiac lesions. So if you have your following, okay, ASD would be well tolerated. Any others? Give a list, 5, 6 lesions. If you've been following a child, they come and present you, they're pregnant, and now that you also find they have a cardiac lesion, you can say, you know what, it's going to be well tolerated. Okay, so mild to moderate valvar conditions. Okay, what else? Moderate shunts. What else? Anything else? Any other lesions? What happens in pregnancy to SVR? Your systemic vascular resistance reduces, right? So actually, valvar regurgitations are also well tolerated. What about post-op patients, like a post-op VSD closure, post-op Fontan? So all these are well tolerated. So if you look at valve regurgitation especially, because this question comes up, say a patient has severe AR, severe aortic regurgitation. When they become pregnant and the systemic vascular resistance drops, valve regurgitation actually improves. So it is similarly like exercise. When you exercise, valve regurgitation actually improves. We don't recommend exercise, competitive sports and so on. But, stenotic lesions, exercise is not a great thing for them. But valve regurgitation, wherever SVR drops, they don't do too badly. So cardiac lesions which are well tolerated in pregnancy, valve regurgitation, mild to moderate valve stenosis, obviously not severe because they cannot increase their cardiac output as pregnancy progresses. Small to moderate left to right shunts without PAH, important to say, without pulmonary hypertension. Congenital complete heart block, and post-op heart disease with good function and minimal hypoxia, such as a post-op TET, Senning, Fontan, that any of those, any post-op with good ventricular function and minimal hypoxia. So name some heart diseases now which are particularly high risk. If you see this patient in first trimester and they have these diseases, you'll tell them, you know what, I think you need to terminate because you are very, very high risk. So name some heart diseases which are high risk in pregnancy. Anyone? Eisenmenger's, yes, Eisenmenger's is very high risk. MS, yes, severe valve stenosis are high risk. So any severe LVOTO, any basically left ventricular outflow tract, that can include aortic stenosis, coarctation, subaortic obstruction, mitral stenosis, because they are not able to increase the cardiac flow. Severe PH from any cause. So pulmonary hypertension from any cause is a risk. And that is why even when we say low risk, VSDs, ASDs, it should be with no PH. So what else? Any other? So we said Eisenmenger's and PH. We said severe LVOTOs. Anything else? What else happens in pregnancy? You have a volume load, right? No, so fontans are not necessarily at high risk. As I said, a well-functioning fontan can fall in a low-risk category because they are pink and they're functioning. Obviously, a failing fontan or a fontan which has a fenestration and they are blue, they are high risk. So what of this statement I said puts at high risk? Anyone? Someone said TOF, right? So anyone who is cyanotic. Cyanosis itself is a high risk, especially for intrauterine death. So if you have cyanotic heart disease, then you're at high risk. Or that's why Eisenmenger's is particularly high risk because it has pH as well as cyanosis. What else? One more thing that is high risk. If you're pregnant, you increase, right, your intravascular volume. So if you have a ventricle that is what? Will it not tolerate? Which ventricles don't tolerate an increase in intravascular volume? Which ones? The ones who are failing, who have low ejection fraction. So poor ventricular function is also a high risk for pregnancy. So left-sided obstructive lesions, pulmonary hypertension including Eisenmenger's, or pulmonary hypertension from any cause, cyanotic heart disease, poor ventricular function. These are they are high risk for pregnancy. And one more lesion where if it is already there, now you intravascularly expand, you run the risk of rupture. So if you have a dilated ascending aorta which is fragile, example Marfan syndrome. So you have a fragile aorta, now you add volume onto it, you can have rupture and dissection. If you have poor ventricular function, you add pregnancy, that ventricular function, that LV will not be able to cope with the demands of pregnancy. You have cyanotic heart disease, the cyanosis will cause fetal demise or IUDs. And pulmonary hypertension, left-sided obstructive lesion, significant risk. Okay, all clear? Amit, when you answer, just put to everyone so everyone can see your answers. And then valve prosthesis are also at high risk because they are also on warfarin and so on. So for which mothers would you recommend a therapeutic abortion? Kind of goes from these, the same answers to some extent, right? So which mothers would you recommend therapeutic abortion? One would be Eisenmenger's. If they're in heart failure, class 3 or 4, if they've got angina, and or if they have severe LV dysfunction, which is, so tell me now the classification of LV dysfunction. I've put here severe LV dysfunction is EF less than 30%. What is moderate LV dysfunction? Is how much to how much? And what is mild? What is moderate LV dysfunction? So moderate LV is not 30 to 35, it would be 30 to 44. 30 to 44 is moderate. And then what is mild LV dysfunction? Mild LV is what? So, well, actually 55 is considered really normal. Yes, so 45 to 55 would be mild. If you're 56, 57%, that's normal here. So 45 to 55 is called mild LV dysfunction, and less than 30 is called severe LV dysfunction. So mothers with Eisenmenger's, heart failure, angina, severe LV dysfunction, or Marfan's with an aortic root of greater than 4 centimeters, these are all patients in whom you would recommend therapeutic abortion. Okay, all clear on this? We'll move to another spotter. What is the diagnosis here? This is a CT angiogram, 3D reconstructed view. So this is a double aortic arch. So you can all see here, this is your ascending aorta, and then you've got one arch here and you've got one arch here circling around the trachea. So how does a double aortic arch present? What are the symptoms? What are the symptoms? So stridor, they will always have, so they don't necessarily have a bounding pulse. Basically, in a double aortic arch, these two, right and left arch go, and as you can see here, the trachea is in the middle. They compress, they press on the trachea. So they typically will present with stridor and respiratory distress. They are not they don't have aortic regurg, and they are not a runoff lesion. So they are not like a PDA or a truncus. So they won't have your bounding pulses. They are essentially what happens in a double aortic arch is you have your ascending, right? Then normally your ascending will go to descending, right? But here it will go through one arch, it will go through the other arch, but eventually they will join up and go into the descending. So ultimately the blood's going into descending aorta, it's just going via these two arches. So in fact they don't really have a runoff lesion, but they have a significant compression of the trachea, which is why you have respiratory distress and stridor as your presentation. Now, a few questions on double aortic arch. I don't know how many of you have done your embryology classes recently, but what remains embryologically? This double aortic arch, what is it embryologically? What are those two arches from? So what remains embryologically? You'll all have to go back to your embryo. What is that book? Oh my God. Langley, the book. So it's a persistence of the fourth arch and the dorsal aorta. So persistence, both the fourth arches persist. Which side is commonly dominant? Right or left? Typically associated the right arch. That means the right side is dominant and left will generally be small. So 75% of cases it's the right arch, the right side of the double arch, which is the dominant, the bigger one. What is the associated heart disease? Can you get associated heart disease with a double aortic arch? So typically these kids will present with stridor and they come, for an evaluation. The pediatrician has looked at everything and then they are sent for a evaluation, and double aortic arch can be picked up on echo because you look to the right. That's why you must always look on suprasternal view to the right of the trachea and left of the trachea to see if you see an arch in both views. So yes, it's relatively uncommon to have heart disease, but you can get VSD and tetralogy. Any associated genetic syndromes with double aortic arch? Can you get associated any genetic syndromes? Again, you can get, it's rare, but you can get 22q11, you can get Bacterils, Charge, Downs. So 22q11 is seen in about 20% of the patients. So about 70% don't have any associated genetic syndrome. Any associated non-cardiac disease you should know of with a double aortic arch? any associated non-cardiac. And this is just, important to keep in mind that they can have associated laryngeal webs. And if a stridor persists after repair, so you've repaired it and they still have stridor, then you got to think of doing a bronch and looking for a laryngeal web. Yes, they can also have esophageal atresia. Presentation we discussed. They can have stridor, and older patients, generally if they survive, you can have some also difficulty with swallowing. But typical presentation is stridor, and acute kind of life-threatening presentations can also occur. So more commonly, it is they present with continuous stridor from birth. What is the best way to image a double aortic arch? You just saw that. You can do it on a CT or an MRI. It's a CAT can also show it, but you don't need to CAT these patients. Echo can also show it, but typically if you diagnose it on echo, you'll send them for CT or MR to look at which is the dominant side, and also to plan your surgical management. Okay, another spotter for you, CT scan showing what? CT scan showing, anyone? Anyone? CT scan showing? This is a spotter. It would be good for, so you can see here, this is your trachea, right? And then you see something going like this. So what is that? So this is a classical LPA sling. So you see this is the left pulmonary artery here, but it is coming from the right side and going over to the left. So this is a LPA sling, and just keep this image in mind, because LPA sling on CT is a spot diagnosis. I'd suggest to all of you to spend, if you have radiology departments, spend some time with the radiologist whenever they're looking at cardiac CTs. So some questions on an LPA sling. Now, how many percentage have CHT with an LPA sling? So 50%. So unlike double aortic arch, where it's quite rare, with an LPA sling you can actually get some PDAs, ASDs, VSDs, left FCC. So half of them will have some associated lesion that you need to look for. Which lung is commonly affected? How do they present? And which lung is affected? So it's basically in the LPA sling. So normally you have your NPA, you have your RPA, right? And then you have your LPA. That's your normal. In an LPA sling, what is happening? You've got this. You have here your RPA, and you have your LPA starting all the way on the left and then going over. So what is the finding that you find on barium, swallow? So it goes between the trachea and the esophagus. So which lung gets most commonly affected? Other organs affected, anyone? So similar to in double aortic arch, you get esophageal atresia, and you can get a congenital laryngeal web. In LPA sling, they can get GI-GUs issues like imperforate anus, Hirschsprung disease, and in half of them they have the trachea, the ring of cartilage, which is only supposed to be, you have your cartilage in part of your trachea, you get a complete ring. And so sometimes you even need to do a tracheal reconstruction for these patients. And that's the importance of knowing that the treatment is you bring this LPA, move it anteriorly, move it in front of the trachea. But if your trachea has these rings of cartilage, you may need to also fix the trachea. So it also needs the tracheal reconstruction at the same time. Lung that is commonly affected is the right, because this thing is going on the right and coming over. So the vessel is on the right side of the trachea and bronchus. Common mode of presentation will be again dyspnea, wheezing, respiratory distress, stridor. And what do you see on a barium swallow in an LPA sling? What do you find? Anyone? You find an anterior indentation of the esophagus because it's going. So this is your trachea, this is your esophagus. It's going between the two. So it presses on the esophagus. So you get an anterior indentation. Everyone clear on that? Why you get anterior indentation? So this is normally, now if I look from lateral, okay, imagine I'm looking for lateral. This is my trachea, right? This is my esophagus, right? Because esophagus lies posterior. This thing is running in between the two here. So where will it press? It will press on the anterior part of the esophagus. Now, once you think on echo, maybe this is an LPA sling, do you need to do a CAT? Yes or no? How many would do a CAT? Anyone else? How many would do CAT? So yes. How many say yes? How many say no? So the good thing is that today, in today's day and age, CT and MR really are sufficient because, you know, with the 3D reconstructions, the CT and MR will actually show you indentation of trachea, indentation of right bronchus, indentation of esophagus, any other issues with the trachea like the rings. You know, all that you won't be able to see on CAT. On CAT, all you'll see is, okay, LP is coming from RP and moving this side. But CT and MR are the, again, the investigation of choice for an LPA sling. Similar to double aortic arch, CT and MR are the investigation of choice. Similarly, in LPA sling, CT and MR are investigation of choice because they can also assess trachea and all the intrinsic anomalies of the trachea, including the fact that the cartilages will have a complete ring around it, and also where there is compression, how the lungs are. All this can be assessed and surgical planning therefore done if you use CT or MR. Okay? This is a spotter for you, genetic. So which syndrome and which cardiac lesion? Anyone? Hexadactyly, polydactyl, and peg teeth. Yes. So this is Ellis Van Creveld, and the cardiac lesion associated with it is the common atrium. Okay, so I want you all to remember this. These images, peg teeth. You see the peg teeth here? Hexadactyly, Ellis Van Creveld, and the cardiac lesion is common atrium. Now, what is the ECG in common atrium? ECG in common atrium. ECG findings, common atrium. Anyone? Left axis deviation of the QRS, you mean superior axis, okay, left axis. Anything else? So it's like a partial AV canal, right? Like a primum. So you get your superior axis. Anything else? You can get prolongation of PR interval, right? Because of intra-atrial conduction delay. So you actually get to see a bunch of things in common atrium. So here, if you see the AVF, it's negative in AVF, the QRS. So that's the left superior axis deviation. You can get your RSR prime in V1, right? And ASD. Your rhythm is usually sinus, but remember, common atrium is not like your secundum ASD or like your primum ASD. Many times you can get abnormal situs in common atrium. So if you have abnormal situs, you can have conduction blocks, and you can even get complete heart block. P waves can be tall and broad because of atrial enlargement, and sometimes you can get first degree heart block because of, again, atrial enlargement, so intra-atrial conduction time is increased. Okay, now what is the spot diagnosis on this ECG? Anyone? Spot diagnosis. Why do you say Brugada? So let's look at the P waves. Okay, so AV dissociation. So let's look at the P. You have the, I'm not sure that's a P or a T. Okay, this is a P, right? Now that's a P. You see this? That's a P coming right after the QRS. That's a P. That's a P. So there's AV dissociation, right? So there's AV dissociation with complete heart block. Why is it complete heart block? Why is it not just AV dissociation with, let's say, a junctions, because of a junctional rhythm? Why are you saying complete heart block? How do you differentiate between complete heart block and a junctional rhythm causing AV dissociation? So your atrial rate is faster than the ventricular rate. That's right. So you see here, let's look between this one and this one. Now, what is your atrial rate here? 300, 150, about 100. What is the ventricular rate? 300, 150, 175, 60, 50. So when the atrial rate is more than the ventricular rate, it is complete heart block. When the ventricular rate is more than the atrial rate, with AV dissociation, it is a junctional rhythm. So this is complete heart block. Now, where do you think is the heart block? Where? Where in the system? Where is the lesion? Do you think it's at the AV node? Do you think it's above the His, below the His? Where do you think it is? So it is suprahischian. It is most likely at the AV node. Why do we think it's at the AV node? Yes. Why are we saying it's at the AV node? Based on what? Why do you think this heart block is at the AV node? Yes, because the QRS is narrow, right? Not relatively narrow, it is narrow. So when you have complete heart block with a narrow QRS, then the lesion is at the level of the AV node. So typically, when it's a suprahischian or at the AV node, you will have the escape rhythm will be your junctional escape. So these will be narrow complex. They'll have a little higher rate, like 45 to 50, 55, 60. These patients will be hemodynamically stable. Heart rate increases somewhat when they exercise. On the other hand, if the block is below the AV node, that means infra-AV nodal, then your escape rhythm will be either from the ventricle, or that means from your Purkinje system, or somewhere from the Hispano. Basically, it will be a ventricular escape rate. There, the rates will be much lower, 45, less like 30, 35, and wider complex, wide complex escape rhythms. Those patients tend to be hemodynamically unstable, and they don't respond well to atropine. Now, congenital, when we talk about congenital heart block, like let's say with common atrium, or with a patient who has isomerism, or with an anti-Rho, anti-La antibody, where it occurs at what level? So congenital heart block occurs at what level typically? At node or infranode? AV node or infra-AV node? Congenital heart block. So central fibrous body, so it occurs at the AV node level, right? So congenital complete heart block typically occurs at the level of the AV node. So how does it present? With an escape rate of 45 to 60, narrow complex escape rate, hemodynamically stable, a response to exercise, and that's why congenital complete heart block, you typically don't have to do anything right at birth. You can follow them along for many years, and you can put in a pacemaker when they're older. Unlike infra-AV nodal block, which you see in things like when you get a viral infection, where patients can be acutely unstable because they have it's below the level of the AV node. Is that clear? So congenital complete heart block, typically at the level of the AV node, typically stable with narrow complex escape rates, which are in the higher range of 50, 55, 60, and therefore typically asymptomatic at presentation. Okay, 5 to 9. I still have some questions. We'll do a few tracings and then we'll end. Yeah. So what is this is a pullback tracing in the cath lab. So what is the diagnosis? From where to where is it? Anyone? So here you have a pressure of about 30, 35. You see this trace, right? And then you get, it goes up to about 75 and you see this trace. So this is this one is pulmonary artery, right? You can see the trace is a PA. It's going like this, down and coming back up, right? Now, is this trace, to say your PS, that means this trace could be an RV, you're saying, right? Now, do you think it's an RV? This one. Is this trace an RV trace? And so I want you to look carefully. So when a PA trace would go like this, down, up, down, right? That's pulmonary artery. RV would go how? Up, down, then slow rise, and then again up, right? You get your slow rise, then you get your up, right? That's your RV trace. Now look at this trace, everyone. It's going down, going up, going down, going up. So what is the diagnosis? So this is from PA to PA. It could be from peripheral PA to MPA. It could be either peripheral pulmonic stenosis or it is a stenosis in the MPA, right? It's a PA trace to a PA trace. And so very important, this slide is very important for whenever you look at a pullback, you need to look at the type of tracing it is. And define, is it a ventricular trace, which always will have an end diastolic pressure going up and then a spike, or is it a great vessel trace? So look at the trace above here, right? This is, again you see, this is an aortic trace, up, down, up, down, up, down, up, down. Look at the PA trace, up, down, right? And look at this, this is also still you can get the same trace in an aorta if it is a wide pulse pressure. You'll get this kind of a trace. And this, in this case, it's an MPA, and the diagnosis is peripheral pulmonic stenosis. Okay, now you compare that with this. What is the diagnosis here? And sometimes it's confusing, but you got to look at one or two beats which will give you the clue. So what is the diagnosis here? So again, you've got pressure of 20 here, right? This is in the pulmonary artery. You've got a higher pressure here. So you know this is an aortic pressure up here, right? Of 100 by 70. And here you have, there's a pullback into, the pressure is about 40 to 50. And look here, you've got your diastolic rising, right? Look here. So this trace, you see the diastolic rising? So this is an RV. So this is valvar PS. And is this mild, moderate, or severe? This is mild, moderate, or severe valvar PS. This is mild. So mild is what? What is mild? Definition of mild? What is the definition of mild pulmonary stenosis? Anyone? What is mild? Mild pulmonary stenosis is, all of you read today, mild, moderate, severe. But mild is gradient less than, well, most will say gradient less than 40, moderate is 40 to 70, severe is more than 70. Or you can take RV pressure less than half systemic. So if you see here, systemic is about 120 or 130, RV is 45. So it's less than half systemic. Moderate is half to two-thirds systemic, and severe is more than two-thirds systemic. So you can use any of these criteria. Okay, I think I'll end with that because it's 9 o'clock. So I'll save these other tracings for next